So now we usually have cases where people have taken ECGs. Okay, so maybe the latest ECG was 10 days back, 15 days back. Maybe they wanted to join a fitness program, so they took an ECG as a precautionary measure to see if everything is fine. The ECG was absolutely normal, and still few days down the line, the person gets an attack in the gym. So what went wrong? Questions often arise whether the machine was made to pick up something or whether the doctor was not competent enough to look at that ECG. How did this happen? A normal ECG and someone gets an attack a few days down the line. So what's going on here? That brings us to this very important question as to what does a normal ECG mean? But imagine what's happening during a normal ECG. You're completely at rest. Your limbs are not moving. Right? You're relaxed. And in that situation, we are checking your heart for adequate blood supply. So what does an ECG mean? What does an ECG do? An ECG picks up electrical activity from the heart. That electrical activity is because of the mechanical activity of the heart. Because within our bodies, the mechanical activity of the heart is stimulated by an electrical activity driven by our nervous system. So the nervous system sends down nerves to our heart, which causes this rhythmic contraction and relaxation. So that electrical activity is what is picked up on our chest. So we have 12 leads that we connect to the chest. The reason for that is we are trying to look at the heart from various angles. So that's why it's like 12 windows to the heart. 12 leads, 12 different windows to the heart. So a normal ECG, a person is absolutely at rest when the ECG is taken. So all the blood that is available to the heart. So in that situation, even if there is, let's say, a 50% block, you may not pick up the changes on ECG. Changes on resting ECG are picked up when the block is critical, which means that even at rest, the supply to your heart is not adequate. Yes. And that generally is a 70% blockage and above. 70% blockage and above. Now the 70% blockage and above, if it's in someone who's a 70 or a 75-year-old individual who has led a very Spartan existence, no smoking, no alcohol, nothing, in his case, there was enough time for collateral circulation to develop around that block. But in a younger individual with the modern lifestyle, it is quite possible that they may have a 70% block and the collaterals have not developed because there was not sufficient time for the collateral circulation to develop. In those cases, 70% blockages can also get picked up on a resting ECG. So what do we do next? If there are changes in a resting ECG, that is already advanced heart disease. So although we use that as a screening modality, it is that resting ECG is actually picking up advanced heart disease. Generally, a screening procedure, we want to pick up early disease so that we can intervene in time. But as far as the resting ECG is concerned, it is not the best test to pick up. I mean, it's not even a test to pick up early heart disease. There are other markers that we'll discuss as we go along, other modalities of doing it. So let's continue with it. Someone's resting ECG is normal. You're still not certain whether he has a heart issue or not. Because like we discussed, it's a resting ECG.
It doesn't pick up early.
Yes. So usually doctors will ask for a 2D group. 2D group. Right? So resting ECG is normal, get your 2D echo done. 2D echo also comes back as normal, generally speaking. Generally speaking, the 2D echo comes back as normal. So what are we looking for in a 2D echo? That's the question. That what are we looking for that we couldn't pick up on a resting ECG? Why is the 2D echo being asked for? So what we are looking for in a 2D echo is something called the regional wall motion abnormality, RWMA. Regional wall motion abnormality.
What is that?
Yes, I'm going to explain that. So imagine this is your ventricles, right and left ventricle. So let's just stick to the left ventricle that pumps the blood to the entire body. So that's the one that is a larger muscle group and requires more blood and is also the one that is affected when there is a critical blockage compared to the right ventricle. Because the right ventricle just has to pump to the lungs, which is not a very high resistance. So the right ventricle is generally not under a lot of strain or stress. It's the left ventricle that is under strain. So when your heart pumps, the whole left ventricle pumps like this in sync. A torque, a twisting action. So this is when your blood supply to your entire heart is normal. But if there is some deficiency somewhere, then that area of that muscle group supplied by that artery which has this blockage will not pump as well as the rest of the musculature. So there is a lag, and that is regional wall motion abnormality. So that's what we are looking for. So will we pick up that when the ECG was normal, resting ECG? Most likely not, because again the 2D goes done at rest. So this 2D goes again done at rest. So it is very unlikely that you will pick up something even on a resting 2D echo. So again you have the situation, resting ECG normal, 2D echo also normal, and still someone 1 month down the line gets an attack. So what happened? We have heard this and we have seen this kind of scenario play out a number of times, and then a lot of questions arise. So how do we pick up underlying heart disease that goes that is missed by resting ECG and the resting 2D? So now we have to put the heart into a challenging situation wherein we are able to pick up those blockages that may appear when the heart is under stress, which means the limbs are also competing for blood with the heart. That's the natural situation that people have these kind of events. Or it could be a stressful event where the heart rate is high. So when the heart rate is high also, there is a sudden increase in oxygen demand, and if there is a blockage, it can precipitate an attack. And by blockage, I mean critical blockage, which essentially is 70% and above. So how do we pick that up? Like I said, you have to exercise the limbs, and that's called Treadmill Stress Test. So can everybody do a treadmill stress test? No. A lot of people, just from sheer overweight issues, they may not be able to do a treadmill stress test. So in that case, we have a pharmacological test where we can artificially raise the heart rate using certain chemicals. But yes, is it still as good as a treadmill stress test? No, because that is again done with the person at rest. The pharmacological stress test is again done with the person at rest. So it is second best. Whenever possible, a treadmill stress test is always best. Where do you do a treadmill stress test? A treadmill stress test is best done in a healthcare facility. Because If there is some acute event, it can immediately be managed. There will be in-house cardiologists, and it may be the cardiologist himself is who's doing the treadmill stress test, and he can pick up those early changes and intervene. He can bring the test to a close and immediately intervene. So, the treadmill stress test is best done in a hospital which has a cardiac facility to deal with any acute event. Now, you must have heard of coronary CT scans.
Coronary CT Scan.
Yes. So, again, whom will we do the coronary CT scans and will it pick up a blockage? Yes, it will. It will pick up a blockage. So, in cases where we don't have a high degree of doubt, we can still do a coronary CT, which means kind of subcritical blockages. Their coronary CT scan can be of value, wherein you can see the architecture of the artery, you can easily see the blockage. There is something called coronary calcium score also that gets picked up on a coronary CT. So it's a fantastic test, and we need uh, trained people, I mean doctors, to be able to analyze and interpret it well. Because a coronary CT scan will again not tell you whether that blockage is, unless it's a high level of block, it's very difficult for those marginal blocks for us to arrive at some actionable intelligence for the marginal blocks. So then should we do an angiography is the question. And in whom should you do the angiography? In cases where we are certain that an intervention will be required, because this is again one question that comes up, angiography versus coronary CT. When do you do the angiography? When do you do the coronary CT? Angiography is an invasive procedure where you either go in through your forearm artery or your arm artery or your femoral, the groin. So we access the heart through a blood vessel. We thread a guide wire and go all the way to the heart, pass a dye through these various arteries that supply the heart, and then we look for blockages. Although a very good test, but we wouldn't want to do this for someone we may think has a low chance of needing an intervention. So, where there is a low chance of needing an intervention, we may prefer a coronary CT as a first step. Someone coming in with an acute heart attack goes directly to the cath lab and gets an angiography. Someone who comes in just for a regular checkup, or there is something that we have picked up on a regular checkup, and he complains of chest pain, but we are not certain that it is cardiac in nature. In those cases, a coronary CT may be preferred as a first step and a less invasive step to an angiography. So let me just summarize the entire protocol. How will we screen for underlying heart disease? So ECG is the first step. You look at a resting ECG. Again, it's a resting ECG. Limbs are at rest. Resting ECG is normal. All that it means is that there is adequate supply to the heart at rest. And if you don't suspect any symptoms, there is no chest pain or difficulty breathing on exertion. In most cases, that's the end. We don't screen further. We take a good history and we release the person for any physical activity that you want wants to take up. We may additionally choose to do a 2D echo. So if that choice is made, that again depends from doctor to doctor and institution to institution. That's fine. So resting ECG and 2D echo is what you would do first. Resting ECG and 2D echo is normal. You still have your doubts. Next, you proceed to a stress test. So now you're going to stress the heart either by increasing the heart rate or pharmacologically. Exercise treadmill stress test would be our first choice. So we will do an exercise treadmill stress test. And if there are two ways now of doing this, people will have the ECG leads on. So when someone comes for a treadmill stress test, we do their resting ECG first. If there are changes on the resting ECG, that person does not go to the treadmill stress test because we have already picked up changes on the resting ECG. Resting ECG is done, and we will also want to do a resting 2D echo. And as an additional modality of testing to corroborate our results. Then the person goes on the treadmill. When the person is on the treadmill, he has the ECG leads. You're monitoring the ECG when he's exercising. If we see any changes on the ECG that is suggestive of blockage, in medical terms we call it ischemia, we will stop the test at that very point. Everything is fine. Then we take the person off the treadmill stress test once he has achieved a certain exercise volume. We measure that in terms of minutes. So when he has achieved a target heart rate and a target exercise volume, no symptoms, he comes off the treadmill stress test. Following that, we can repeat the 2D echo again. So before at rest, we did a resting ECG and 2D echo. We put the person on the treadmill stress test. We were continuously monitoring his ECG. On a moving person, you can't do a 2D echo. So when he comes off the treadmill stress test, we repeat the 2D echo. That is called a stress echo. Commonly called a stress echo. So that has this additional benefit that if something is missed by one test, maybe the other test will pick it up, especially the regional wall motion abnormality. Now let's say the ECG did show some changes, and that same area of the heart is also showing a regional wall motion abnormality on 2D echo. It corroborates our findings. There is the pharmacological stress test that we were talking about. That is the second option that we have when someone, let's say, is overweight or having arthritis of the knees and can't do a regular treadmill stress test. Then the pharmacological stress test is done, where we use one dye to increase the heart rate, and we use a second chemical which lights up the heart differently. So red, yellow, orange, depending upon the amount of blood supply to a particular region. So that from that color coding, we are able to ascertain where the blockage is. So that's the pharmacological stress test. Coronary CT, again, like I said, we feel there needs to be an intervention. So in that case, we have two options. Someone coming in with an acute MI to the emergency, ECG changes, goes straight to the cath lab. Someone comes for a regular checkup and you feel there is something that you're still not able to pick up on a treadmill stress test, but you're not clear. And in that case, you will not send him for an angiography. So just to be sure, we will go for a coronary CT. If we are certain there is a change on the treadmill or the pharmacological stress test, then we will not choose the coronary CT. We will go for the angiography because here we may have to intervene as well. So that sums up our discussion, which we have had for the last 15 minutes.
Okay. Thank you.